Me and Megan did our research paper on interventional radiology. For our presentation, we did an interview with Mr. Jack Mayu. He has a bachelor's in nursing. He's worked at the cath lab for the lake for 5 years. Can you tell us a little bit why you would or wouldn't do a procedure?
Okay. So the reason why you do a heart cath is anytime someone is having chest pain, shortness of breath, or we think they're having a heart attack. Okay. Generally, a patient comes in, goes sees their doctor. If they're not having a heart attack, they go in, they're having chest pain, shortness of breath. They're not sure why. They'll do some tests and ultimately determine, yeah, they probably have a blockage, or we think they have a blockage in their heart. So then the next procedure is a heart cath. A heart cath, you can do. I'm sure y'all know about. They do like CT angiograms and nuclear studies and everything like that. All that can show, yeah, you have a blockage, or no, you don't have a blockage. And most people say, oh yeah, the test said I had a blockage, so I'm going to get a stent. Not really. Those tests tell you that you have a blockage, but they don't tell you how much and where it's at. The heart cath is the definitive answer. This is the ultimate test. Okay, so when you come in for a heart cath, when we do the procedure, you know exactly where the blockage is and how much it is. Now, typically, we don't fix blockages in America if they're less than 70% blocked. Okay, so anything less than 70%. So if you come in, you have a 50% blockage in one of your arteries in your heart, we won't do nothing with it. We'll just send you home, the doctor will change up some medicine, put you on medicine, and then they'll just watch you. So that's the main reason why. Now, of course, other people that come in for a heart cath, they're having a heart attack right there. They come into the emergency room, call 911, they go into the emergency room. Now that one we're pretty sure, So they'll come in, we'll do the procedure, and this is whether they're having a heart attack or not. We'll take pictures, shoot angios, everything like that. If the blockage is not enough, we won't fix nothing. If it's in a spot 70% or more, we'll fix it. Now, we can't fix every blockage. There's some spots in certain arteries that we can't fix. So if it's a main artery, something big like that, then you have to go for heart surgery at that point. You have to do bypass surgery. If it's in a spot that we can, then we'll put in, we'll usually do a stent. A lot of people say, well, do you just do a balloon and not a stent? They used to, but they don't do that anymore because they showed that if you do a balloon without a stent, then within 3 to 6 months, you got the blockage back there again and have to go back in and do it. So they'll put a stent in, and then you're done. I mean,
some of the reasons why you wouldn't do a heart cath.
It's if you're coming in with a heart attack, having a heart attack right there, you come into the emergency room. There's really not many reasons why we wouldn't do one, because if we don't do it, you're probably gonna die. The main reason I can think of that you wouldn't do one if you were actually having a heart attack is if you fell and they thought maybe you had a bleed in your brain, then you're gonna go to CT first, make sure you don't have some kind of bleed before you come to us first. Even after that point, you'd still come to us. And would we do anything if you actually had a bleed? I don't know. So that's a whole different round. So that if you're having a heart attack, we're gonna do it because you're gonna die. If you're not having one and you just go to see your doctor and they say, oh yeah, we think you have a blockage, you're having chest pain, shortness of breath, then it becomes elective. So there's reasons why we would delay it, but eventually you can get it done. So one of the reasons why we delay it is kidney function. Anytime you give contrast, you got a lot of kidneys. So creatinine, all that stuff. They'll draw labs. If your creatinine is high, doesn't mean we won't do it. It just means that there's certain medicines that we can put you on before and after the procedure that'll protect your kidneys. We can give you a lot of fluids, all that. There's certain things that we can do to help protect your kidneys. So we'll do it. We may just, instead of doing the next day, we may do it 3 days from now. Another reason we might delay it would be allergies. If you're allergic to shellfish, contrast, iodine, and there again, we wouldn't necessarily do it the next day, but we'll do it 2 or 3 days from there, and we'll just put you on medicine to help keep you from having an allergic reaction. Another one would be bleeding. If you were taking a blood thinner, like Coumadin or some of these other blood thinners that they have, there again, we would just delay it. So you wouldn't necessarily do it the next day, but 2 or 3 days from now, we would do it. We would just stop that medicine. So as far as reasons why we wouldn't do it, the only for sure reason I would say, and this probably wouldn't even be for sure, but that we wouldn't do it is if you had some kind of cancer or something like that and you were terminal. So if you want hospice care, we wouldn't do it. There would be no point. You're already on hospice care. So, and if there was something major like that, you had some kind of terminal illness or cancer where you weren't going to live much longer than a couple months, then we wouldn't do it because there wouldn't be no benefit. So the benefit has to outweigh the risk. So you have the risk of, stroke and all these things like that. So the benefit has to be, you need to have enough time, enough life to live to where the benefit of us fixing.
All right, can you explain what an x-ray tech needs to do in the cath lab from the beginning of a procedure all the way to the end?
All right, so usually x-ray techs have 2 positions. They'll either scrub, which is assisting the doctor, or they can monitor the procedure, which is doing all the charting during the procedure. So if you're monitoring in the cath lab, typically what we do is the nurse and that person, it doesn't have to be right there, but it usually is right there, will go and get the patient. Of course, you got to go wherever in the hospital, go pick them up, make sure it's the right patient, everything like that, bring them down, okay? If you're scrubbing, your job is usually, while they're going to do that, you set up the whole table. So that means you open up all the instruments, all the items that are needed for the procedure, everything's set up, ready to go. And then once the patient gets there, you'll help the nurse and everything like that. We'll get them over on the table, get them all, you got to shave their groin, you got to prep them, blood pressure cuff, get them hooked up to monitors. Everyone helps with all that stuff. The person who's monitoring goes and starts entering their information into the computer system. And then once they're all hooked up to the vital signs, EKG, blood pressure, oxygen saturation, everything's prepped, you'll drape them. So that means you'll clean the area, like when you do the surgery, so like not betadine, but the Chloracet, the little sponge thing.
Yeah.
You prep it there. There's a big sterile drape that comes all over the patient's body from the neck down. And there's like a little window right here in the groin. Okay. And then after that, basically, if you're monitoring, you just enter in patient information. And throughout the procedure, what you do is every time we do something, you just chart it. Okay, so the doctor arrived, you click a button and it shows that time. We got artery, click a button, it shows that. You document everything that we do. If you're scrubbing, which rad tech always has to scrub in the cath lab in Louisiana anyway. What you do is once the patient's set up, you'll get some other items set up, get everything ready so that way when the doctor gets there, they scrub in and you begin the procedure. Now during the procedure, you'll assist the doctor. So have everything laid out on the patient. They'll get ordering, you hand them everything that they need, and then during the procedure, it depends on the physician. Some physicians want you just to inject contrast, and they'll move the camera on the table. Some physicians want you to do everything. Some physicians don't want you to do anything. They'll do everything, you just stand there. So it just depends on them. But you can go from the extreme of you'll move the camera to different angles, you move the patient and inject all at the same time while he's standing there, or you could just stand there. And it just kind of depends on which position you're with.
Is that it?